Good morning, good afternoon, and good evening to everybody who's joined us to this 15th HGF webinar on engaging the private sector on health system and health service delivery, the challenges and opportunities in Asia. This is a collaboration between the Asia Pacific Observatory on Health System Policies and the HGF program in WHO. My name is Nima Asghari. I am the director for the Asia Pacific Observatory on Health Systems. I want to welcome you all and thank the HGF program for helping with this collaborative effort. This is based on a piece of work that APO is finalizing at the moment, looking at the health systems and the role of the private sector in those systems of Thailand, Philippines, and Japan. So just to introduce the panelists, we have myself. My name is Nima Asghari. I'm the director for the APO. We also have Gabrielle Appleford, who is the public health specialist with specific subject expertise in health governance and health system strengthening and private sector engagement. And she's also the research and learning channel lead on the country connector for the private sector in health at the WHO. She'll be talking a little bit about the country connector. Then we have Ms. Anika Islam Marshall, who is a public health researcher based at the International Health Policy Program in Thailand. IHPP is the in-house think tank of the Ministry of Health in Thailand and a close collaborator with APO. That then will be followed with the presentation on Japan by Professor Haruka Sakamoto. Haruka is an associate professor at the Department of International Health at Tokyo Women's Medical University, and she's also been editor for a number of APO health system, country health system evaluations, APO hits for Japan and for Sri Lanka. Following that, we have Professor Manuel Darrit, who is the professor and former dean of the Ateneo Manila University School of Medicine and Public Health. Manuel has also been working with the WHO with APO for a long time. He is the lead author for the Philippines Health System Review, published by APO. And he was an ex-secretary of health in the Philippines. And finally, we have Dr. Eduardo Bonzo, who is the principal health specialist in the Southeast Asia Regional Department of the Asian Development Bank, as well as being an honorary visiting professor at the Sosui School of Public Health in Singapore. I'm going to start very briefly about the APO. So APO basically is a partnership of governments, development banks, WHO, and the academic and policy institutes. It was established 10 years ago and is hosted by WHO, and it moves between WHO Southeast Regional Office and WHO Western Pacific Regional Offices. It was created as a mechanism to generate evidence on health systems in Asia Pacific for use for policymakers in Asia Pacific. And we work very closely with a number of research consortium. We have 4 research consortiums. There is the National University of Singapore Consortium, the India-China Group Consortium based in actually India. We have the University of New South Wales Consortium in Australia, which covers primarily Pacific Islands. And we have the International Health Policy Program Consortium, which is based in Thailand. What we produce are 3 or 4 different parts of publications. We have regional policy briefs, we have comparative country studies, and we have health system reviews, the HITs, as well as, because of COVID, having a series of publications about the health system monitoring and response to COVID. So their publications are a means of trying to do evidence on effective health systems and solutions, and as a means of cultivating evidence-informed policymaking process in Asia Pacific. The process that we do that is slightly different to other observatories because we are very much involved in capacity building by doing, which means that quite often a lot of our publications are done by researchers in countries, and that process means that it opens their skill sets and eyes to the much wider challenges of the health system as opposed to the very narrow specialized units that they might be working on. And we engage on policy dialogue, seminars, conferences when it comes to actually showing and showcasing our publication. And our primary audience within the Ministries of Health are the wide group, including disease departments, as well as the planning departments, as well as the policy advisors. But outside of Ministry of Health, we would like to become a provider of tools when it comes to parliamentarians, when it comes to bodies outside of health, which have a direct impact on health, such as national economic planning forums and departments. the development partners in the countries, as well as policy champions to convey specific messages, especially when it comes to policy briefs. And finally, it's the academics. I'm going to finish in here, and I'm going to hand over to Gabriel, who will talk about the country connector. Hand over to Gabriel. Thank you.
Thank you very much. And I will just have a brief presentation to tell you a little bit about the work that is being done by the Health Systems Governance and Policy Department at WHO Geneva, particularly focused on private sector engagement. So starting with the strategy, this was published in early 2020. And it was intended to guide countries on delivering a well-governed health system in which public and private actors collectively deliver on public health goals, health security, UHC, and health systems resilience. So the timing was quite apt with the pandemic. Further, it was intended to build consensus around the means and strategies of engaging the private sector in healthcare delivery. Next slide. Through the strategy, we introduced the governance behaviors, which were intended to convey goal-oriented interaction. So the 6 behaviors are on the screen. I won't read through them, but essentially these are simple descriptors to convey behavioral intent, recognizing that behavior change is not a quick fix, but a series of connected actions, and that government ultimately sets the lead as steward of the health system. Next slide. I wanted to further introduce the country connector on private sector and health. You're welcome to visit the site. The purpose is to share the resources, tools, and guidance for better public health policy towards the private sector and health. We work by sharing experiences across countries, connecting countries to resources, tools, and guidance, and coordinating efforts of multiple actors. In terms of audience, our primary audience is intended to be country level, and that includes member states, governments, private sector actors. A secondary audience for us is the funding agencies, multilateral agencies, implementing partners, civil society, and consumer representatives. Next slide. So this is a bit of a process that we use for country engagement. I won't go through all of the steps, but I would like to say that this is done through one of our channels, which is called the support desk. It links very much with the work that I do on research and learning, but our intention is to start with recognized priorities within countries, so really focusing on context and looking at where private sector plays a key role or potentially could play a key role. We've developed various frameworks and tools, which we hope will guide countries on diagnosing policy vacuums and ultimately governance behaviors. And we would like to take people through the full cycle that is exhibited on the screen. Next slide. We do have a number of country support works in progress. Some of these are represented on the screen. A lot of our work to date has been done in the African and Eastern Mediterranean region, but we're certainly hoping that that will expand to other regions. So some of this has included very bespoke trainings, such as the one we did a week ago for the Afghanistan Ministry of Public Health, to broader engagements, one of which is looking at a 16-country private sector engagement workshop in November. Next slide. I just wanted to end with a few key messages that the strategy is intended to serve as a guide for WHO and member states at various levels of engagement to promote, to sort of re-energize new ways of engaging with the private sector. We introduce as part of that the 6 governance behaviors. We've got various documents that can explain that in more detail. The country connector on private sector and health, we encourage you to engage with that. And we are facilitating a lot of active engagement through that. And that we've got an online course that also exists on the connector that is available in a wide range of languages. And we encourage you to take that. Thank you.
Thank you, Gabriel. So we're going to delve in directly into the first presentation, which is being given by Anika, and it's the country case study for Thailand. And Anika, please go ahead.
Hi, thank you, Nima. I'm Anika, and I'll be presenting on the case of Thailand. Early and sustained public health infrastructure development since the early 1970s has resulted in complete geographic coverage of public facilities, including health centers in all sub-districts, secondary health hospitals in all districts, tertiary care facilities in all provinces, as well as more advanced referral hospitals in all 13 regions. As a result, the health service delivery system is mostly publicly dominated. The hierarchical public service delivery system has provided a promising platform for successful UHC implementation, with primary healthcare units playing a particularly important role as gatekeepers for higher level care within UHC. Historically, MOPH did not play a large role in the expansion of public health facilities in major cities such as Bangkok. This gave room for private sector growth in response to high demand for care by the growing urban population. As you can see, while private hospitals only contribute to 16% in the country, they have a much larger role in Bangkok. Additionally, private clinics acting as primary care units play a very significant role, contributing to 75% of primary care units in the whole country. And this is 99% in Bangkok. Thailand has achieved UHC in 2002 with the whole Thai population covered by one of the three main public health schemes: the Civil Servant Benefit Scheme for government employees, social health insurance for private sector employees, and the UC scheme for the remaining populations, which make up 75% of the total population. While the CSMBS Civil Servant Scheme only provide access to public health facilities, the Social Security Office, or SSO, and the National Health Security Office, or NHSO, contract with both public and private facilities to provide health services to those covered under these two schemes. So there are three main facility types that the two organizations contract with. Main contracting units provide full comprehensive prevention, health promotion, and curative services. Primary healthcare units act as gatekeepers to these main contracting units and provide primary care services to the catchment population within a set geographic area. The referral units are affiliated with the main contracting units to provide care that may be beyond the capacity of main contracting units. So while NHSO contracts with all three facility types, SSO actually only contracts with the main contracting units while allowing each main contracting unit to subcontract further with other private primary care units or referral hospitals. NHSO primarily provides health services to members through public facilities, with private facilities only contributing to 5% of all health facilities contracted with NHSO. However, private facilities have a very significant role in Bangkok, with 67% of facilities being private. SSO members, being private sector employees, residing mostly in urban areas, have to have more access to private facilities. So SSO does contract more with private facilities than NHSO. As a result, 33% of all health facilities within SSO are private. And similarly to NHSO, in Bangkok, it's around 60%, so much larger population. NHSO and SSO both have separate requirements facilities contracted. This includes licensing, standards, accreditation requirements, as well as hospital capacity, including doctor to patient ratio, number of hospital beds, as well as specialties. For NHSO, new facilities can submit applications at NHSO regional offices and undergo evaluations by the assessment committee, including meeting facility requirements and passing inspections. As part of contractual agreements, private facilities may face penalties for breaking contractual agreements, and NHSO can, and in the past, has terminated contracts with private facilities when the private facilities have violated the agreements or are found to be corrupt. And this includes false claims, as well as the use of ghost patients to increase the capitation. SSO has a very similar contractual process. However, next, unlike NHSO, which conducts facility inspections themselves, SSO only relies on JCI and HAI inspection results for service providers. And while NHSO automatically renews contracts with previously contracted private providers, given they continue to meet NHSO requirements, all private facilities within SSO have to undergo new application, new registration, and new contracting terms annually. NHSO pays for outpatient services and general health promotion and disease prevention services prospectively 1 month in advance by capitation based on an age-adjusted differential capitation rate and the number of registered members. Elderly and the children under 5 have a higher capitation rate. Inpatient services are paid through retrospective claim and reimbursements by applying a diagnostic-related group system under a global budget. Reimbursement payments are also used for special health promotion and disease prevention services in cash or in kind for specific services such as vaccines, antiretroviral drugs, and peritoneal dialysis solutions. Additionally, a fee schedule under a global budget is applied for high-cost services that may pose financial risks to health facilities, such as knee prosthesis and high-cost medications, including acute ischemic strokes. And fixed fee per patient for some non-communicable diseases, screening services, and a point system with a global budget are used for acute diseases, emergency services, Thai traditional medicine, as well as rehabilitation services. And the final one is project-based contracts. So these are used for community-based health promotion and disease prevention services that meet the local health problem needs. And this is managed by the NHSO regional offices and are paid as block grants to sub-district health centers. For SSO, they also apply a blended payment mechanism, but outpatient and inpatient services are both paid monthly based on a capitation rate. This is around 1,500 to 2,000 baht per registered member. For inpatient care, uses a DRG system. For inpatient care with an adjusted relative weight of over 2, uses a DRG system. And additionally, to incentivize providers to provide adequate treatment for chronic diseases, an additional payment of around 500 or so baht per registered member is allocated, 50% paid monthly, and the remaining 50% paid at the end of an annual contract, subject to quality performance earned by a point system. Certain equipment and preventive services can also be reimbursed using the fee schedule. So SSO pays 80% of the amount of expenses that are over 1 million baht for high-cost services. NHSO has introduced various mechanisms to monitor health facility performance and ensure service quality. The Standard and Quality Control Board of the NHSO sets and monitors the standards and quality of health providers. They're both national and regional standards to ensure applicability to different regional contexts, including criteria for new entry and contract renewal. Apart from new entry and renewal requirements, NHSO also can conduct unannounced surprise visits to health facilities, which are chosen based on those suspected to be non-compliant to NHSO requirements through documentary audits, and also complaints received by members through phone call or written complaints. They also just conduct random checks as well for different private facilities. NHSO also provides financial incentives to hospitals based on the achievement of HIA accreditation by applying a scoring system with a maximum score of 5 for hospitals with full accreditation and 1 for those achieving one-step HIA accreditation. In contrast to NHSO, while SSO does conduct assessments and quality control audits, SSO does not proactively incentivize hospitals for continuous improvement. The office only really relies on the Healthcare Accreditation Institute or the Joint Commission International as conditions for private hospitals to enter agreements. So the main takeaways are that the private facility in Thailand only really plays a role of filling the gaps of public facilities, and this is primarily in the urban settings. Only 2 of the 3 main UHC providers contract with private facilities, and this is through assessments to meet quality and capacity standards, and they all have to meet legal and reporting obligations and have clear payment terms. To highlight the difference between the public and private providers is that private providers have to have very clear contracts, whereas public facilities don't necessarily. NHSO has a stronger audit and oversight capacity with legal sanctions than SSO, And they both do provide blended payment mechanisms to improve access to high cost but effective interventions, while at the same time minimizing the weakness of potential under provision of services of the main mode of capitation payment. NHSO, however, uses capitation only for outpatient and DRG for inpatient services, while SSO use capitation for both inpatient and outpatient while applying DRG for inpatient services that have a higher relative weight. Thank you.
Thank you very much, Annika, for that overview of the Thai health system and role of the private sector in service delivery. Can I now move to Haruka for her presentations on the Japan country case study?
Hi everyone, my name is Haruka Sakamoto, and I'm Associate Professor at Tokyo Women's Medical University. So today, I'd like to talk about the role of the private sector in Japan. First, let me talk about the characteristics of the Japanese healthcare system. The two features of the Japanese healthcare system are the universal health insurance system and the uniform fee schedule. The first one is the universal insurance system, which was established in 1961, and everyone living in Japan is required to join this scheme. Under the universal health insurance system, by paying the monthly insurance premium, people can receive medical care with a certain level of the co-payment. The co-payment rate varies slightly depending on age and the incomes, but is generally set at 30%. The second point is the uniform fee schedule. The government set the price of all the medical procedures and medicines and revise them every 2 years. And these prices applied not only to the public, but also to private medical institutions, and the uniform in both large cities and the rural areas. The universal health insurance system allows people to access medical care without any financial hardship. At the same time, the government controls the price of medical procedures and drugs so that medical costs do not increase. In light of these characteristics of Japanese healthcare system, I like to look at the governance, financial resources, healthcare delivery system, and human resources, especially in terms of the contrast between the public and the private. First, regarding the governance, Japan is divided into the 48 prefectures, which are further divided into more than 1,000 local governments. The Ministry of Health, Labor and Welfare set the national policies for the country as a whole, and the prefectures and local governments are responsible for the actual provision of the medical services. As explained at the beginning, the central government has a very strong authority as it has the power to determine the healthcare prices. In addition, medical institutions are subject to licensing for opening and periodic inspections thereafter, with no difference in the standards between public and private institutions. The same standards and regulations apply to both public and private. Regarding the finance, as I said before, a fee schedule is one of the most important features in the Japan system. So the government set all the prices, both for the private and public institutions, which makes it even difficult for the private medical facilities to set their price. So for example, let us assume that government set the price of appendicitis surgery at USD $100. This price is the same in both private and public medical institutions. Under universal health insurance, a co-payment rate is US $30 as an out-of-pocket payment, while the remaining $70 is reimbursed by the insurance. This scheme is exactly the same between the public and the private. Next, I'd like to discuss Japan's healthcare delivery system. Another characteristic is that the overwhelmingly majority of the medical institutions in Japan are private. In fact, more than 80% are private medical institutions. However, the tertiary care is mainly provided by the university hospitals and then large public hospitals, while most of these private medical institutions are clinics or small to medium-sized medical institutions that provide primary and secondary medical care. It is also said that there's basically no difference in the quality of medical care provided between the public and the private. The government set the types of medical procedures and the price that are covered by the public insurance, And these settings are applied to both private and public medical institutions, which means that individual medical institutions do not have a great deal of discretion. And as a result, that quality of medical care is almost the same between the public and the private. Regarding the medical human resources, again, there's no significant difference between the public and private sectors. For example, it is common in all countries that there is a shortage of medical personnel, especially in the rural areas. The same is true in Japan, where there's a shortage of doctors in rural areas. However, when looking at the public versus private sectors, there's no such public and private sectors, there's no such things as a greater concentration of human resources in private medical institutions. The maldistribution of medical personnel depends more on the types of specialty, acute or chronic care, location, rather than on whether it is public or private. In terms of the compensation, again, it is almost the same between the public and the private. Next, I would like to talk about the challenges faced by the Japanese healthcare system, especially by the private healthcare providers. This challenge became more apparent during the COVID-19 when the number of patients surged. I think the major challenges in every country was in how to deal with that surge in the patient, and it was the same in Japan. And then concern is how to increase the capacity both for the hospital bed and then also the human resources. Please see the third point of this slide. This data is as of October 2020, and at that time, nearly 80% of public medical institutions were accepting COVID-19 patients, while only 19% of private medical institutions were accepting COVID-19 patients. The reason for this low number of patients accepted by the private medical institution is that the private institutions were not equipped to deal with an infectious disease patient. Also, in many countries, the government temporarily increased the number of the hospital beds or forced medical institutions to accept COVID-19 patients. But in the case of Japan, the government does not have that much authority even in an emergency, and then could not force private institutions to accept COVID-19 patients. One particular problem was the lack of the system to consolidate the rapidly growing number of the COVID-19 patients into a single location where they could receive all the medical services they needed. So I'd like to dig deeper into this point. Here is a number of the hospital beds per population in Japan. On the far right is Japan, and next to is South Korea. And you can see that these two countries have a significantly large number of hospital beds per population. On the other hand, this is a number of the physicians per population. The leftmost is Japan, but the number of physicians per population is conversely lower than in other high-income countries. In other words, Japan has a very large number of scattered medical institutions, many of which are private medical institutions, to which a small number of medical personnel are assigned, resulting in a very inefficient healthcare delivery system. For example, in the case of COVID-19, it would have been possible to consolidate both patient personnel in a large medical institution. In the case of Japan, however, medical institutions with only a small number of beds are scattered throughout the country, and it took a great deal of time to coordinate how and where to allocate the rapidly increasing number of the patient. In fact, this inefficiency in the healthcare delivery system has been pointed out even before the COVID-19. Japan has already entered a phase of population decline, and in anticipation of a future decline in the demand of medical care, Ministry proposes to improve the inefficient regional medical care delivery system, including the consolidation of small and medium-sized private medical institutions. It is called the Regional Healthcare Vision. The plan aims to calculate the number of hospital beds needed based on the projected medical care demand and demographics of each region. And within this plan, to build a better medical care delivery system in the region through necessary cooperation between public and private medical institutions. Currently, regional medical plan has been halted due to COVID-19. However, as I mentioned earlier, 80% of Japan's medical institutions are private medical institutions, and there's no doubt that this very large number of private medical institutions have played a major role, especially in terms of improving access to healthcare services. On the other hand, it is difficult for the individual private medical institutions to establish and operate large-scale medical institutions on their own, resulting in large number of small and medium-sized hospitals. While the government certainly has a strong authority in determining healthcare cost, its influence on the management and consolidation of private healthcare institutions is very limited. So in summary, in Japan, more than 80% medical institutions are private, and the government has a very strong authority over them, especially for the fee schedule. In particular, the government determines the price of all medical care throughout the uniform fee schedule system. As a result, when viewed at the level of medical institutions, there's no significant difference in the quality of medical care provided there or in the working environment of medical personnel. This is a good thing for patients because they can receive the same quality of medical care at the same price, regardless of which medical institution they go. On the other hand, Japan has an inefficient healthcare delivery system with a large number of small and medium-sized private small hospitals that acts as the main provider of the services. This is a problem that has been pointed out since before the COVID-19, but the progress has now come to a halt as the consolidation is not as easy as in the public sector. In Japan, the aging of the population tends to be the focus of attention, but the fact is that we have already entered a society with a declining population. And in the medium term, the demand for medical care is expected to decrease along with the decline in the population. In this context, the challenges for the future will be how to promote and consolidation of private medical institutions while building an efficient medical care delivery system in each region. Thank you very much. I would like to conclude my presentation here. Thank you for your attention.
Thank you very much, Haruka, for that detailed presentations on the role of the private sector and the challenges. Can I move now to Manuel, who is going to present about the Philippines?
Thank you for the organizers for this opportunity. I'm essentially going to tell you the story of the journey towards universal healthcare, and from the point of view of the private sector. And I will give you the characteristics of the private sector. But in that journey, I'm going to talk to you about the role of PhilHealth, the Department of Health and local government units, essentially towards the journey. We've been working on our health system for quite a while, and many laws have been passed. But still, can you click again? We're still not UHC capable, you might say. And therefore, if you look at the characteristics of a country, which is archipelagic, we have a mixed public-private system. And our public health system is devolved. It was devolved in 1991. And this has been one of the structural characteristics of our system that makes it quite difficult to reach UHC. But we had a national insurance program, which was enacted into law in 1995. So we have PhilHealth, which is the national insurance company. But our out-of-pocket contributions to total health expenditure is still quite high, 45 to 50%. And you can see the figure there for 2020. So I'm going to talk to you essentially about the private sector. And as you can see from this slide, the private sector has a substantial percentage of hospital-based care. And you can just look at the last line in that slide, particularly level 2 and level 3 general hospitals, which are basically private sector. And when you look at the other facilities, you can see that private sector really has a dominant role in our system, in our very mixed system. Now, when you now think of total health expenditure, this slide is going to tell you that hospitals actually get a lion's share of total health expenditure, which makes our system really very hospital-oriented. And if you look at primary healthcare and preventive healthcare over 2014 to 2019, it's 12% compared to expenditures on hospitals. And now looking at PhilHealth, which is the National Insurance Corporation, you can see that the share of PhilHealth reimbursements is heavily private sector. See that line from 59% to 63% from 2015 to 2020. That shows you the huge role of the private sector in hospitals. And that second line there, which says corporations, those are the large private hospitals. which have a huge share in reimbursements for inpatient care. Now, I want to show this slide to tell you that inpatient care, the expenditures there from PhilHealth dominate the reimbursements. And that line on primary healthcare, that's actually the primary benefit package of PhilHealth, which is almost negligible. So you then have a system which is very hospital-oriented, dominated a lot by private sector. Therefore, the bias towards urban-based care, the bias towards cities where you have a conglomeration of hospitals, and also a bias towards the more affluent who can afford fee-for-service. So two big ideas then in our journey towards universal healthcare. This was the act that actually causes the inflection point in our system. Because technically now, or theoretically now, all of the 110 million Filipinos are covered by universal health insurance. And the first big idea here is that PhilHealth is going to contract public and private healthcare provider networks. That's the big idea. This is essentially a functional integration of our healthcare delivery system. That's the first big idea in where you're talking about individual-based health services. And the second big idea is this. Remember that we are a devolved system. But because of the law, we're having now to functionally integrate in our provinces, in our cities, what we call province-wide and city health systems. And therefore, the Department of Health will contract these systems for population-based care. So these two, you might say, domains of healthcare services, individual-based care, which is going to be funded a lot by PhilHealth, and population-based care, which is going to be funded by the Department of Health. And this is the next few slides are going to describe to you how it's going to look like. So this is the healthcare provider network, the first big idea. And you can see there on the left, the public healthcare provider network, which theoretically should go from the primary level all the way to the tertiary level, all integrated across geographic and political boundaries. And this public care network should deliver population as well as individual-based care. And on the right, you have a purely private system. Again, that pyramid from primary all the way to tertiary. And therefore, think of the country as having these types of healthcare provider networks, public and private. And where you're going to mix them, if you can, you must have contractual arrangements between your public and your private providers. So this is the big concept that needs to be implemented. And we are really in the process now of trying to roll this out. And in fact, local government units are being selected to do advanced implementation of these healthcare provider networks. This summarizes everything. So that's the pyramid over there, from primary all the way to tertiary. What you should be looking at here is the Special Health Fund. The Special Health Fund is a fund that the province or the city, which are the local government units that are going to implement this program, they have to manage the Special Health Fund, which will receive funds and resources from the national and local government budgets. They will receive funds from PhilHealth, particularly DRGs for inpatients. They may receive extra payments, including out-of-pocket expenses, if they're still going to be there. And the city or the province will have to manage this and finance, you might say, this whole pyramid, which can be a mix of both public and private networks, or purely public or purely private. So you can see from this slide how complex this transition is going to be. Because from a predominantly fee-for-service system, where private sector provides services, gets payments from PhilHealth reimbursements, as well as out-of-pocket expenses, you're now going to ask the private sector to join into these networks. And theoretically, they're saying that these funds are going to be paid to these networks. They are not going to be paid to the facilities themselves. At least that's what is being envisioned for the system. And therefore, in order to make this work, and this is going to be my last slide, you will need non-contractual and contractual arrangements. And these contractual arrangements will happen between PhilHealth and the networks. They will also happen between the local government units and the various facilities. As you can see there, different types of contractual arrangements from build, operate, and transfer, joint ventures, et cetera, et cetera. Therefore, let me end with this last slide by saying, essentially, what the Philippines is trying to do within this next few years is to move from a hospital-oriented fragmented system to a functionally integrated system where you have healthcare provider networks, province-wide and city-wide health systems. You will need provider accreditation. You will need citizen enrollment. You will need fraud prevention and detection. You will need new payment mechanisms that the system is not used to, global budgets and capitation. These are very new things within our system. And therefore, you can see the challenges for the Department of Health, for PhilHealth and the local governments, for their management capacities to make the system work. And it's getting to have these government agencies do their job well, which is the challenge going forward, as well as getting the citizens oriented to changing their behavior, because they will have to be enrolled in these healthcare provider networks. And theoretically, they will move through the primary system before they can be referred. But, Filipinos are not used to that. They usually go to specialists without bypassing the primary system, as we saw very much in the situation during COVID. And finally, we're having to deal with our own human resource issues, nursing shortages, pressures of outmigration. And therefore, all of these are coming to bear in our journey, so to speak, to attain universal healthcare in the country. Thank you very much.
Thank you, Manuel. Highlighting the challenges of basically bringing a whole new system in place in a devolved country, which just duplicates that. And now can I ask Dodo, can you start with your presentations?
Thanks. So basically what we, the Asian Development Bank, has been doing is that, we look at the private sector as a partner for development. And so also in the health sector, we have been looking, studying, and how the private sector, how countries, our developing member countries, have been harnessing and engaging the private sector for universal health coverage. So I think a question that usually being asked is, why engage the private sector? And so the answers we've been getting from countries is that the private sector will bring in technology, will bring innovation. There's always this efficiency story that they are always being said to come from the private sector, modern management skills, and housing capital. There's private sector funding that government also wants to mobilize. So, and it has these great opportunities that if countries could actually get this right, that they could get the best of both worlds, the strengths of both the public and the private sector. It also basically, and in the countries, and a lot of the countries that we're working in, Asia and the Pacific, the private sector has always been seen as a partner in other sectors. So it's not, and they have actually seen how the private sector has become champions of these countries. And also there's a desire that if done right, you could actually incentivize the private sector to do things for the delivery of more public health goods, including health prevention and health promotion. But there's always a lot of challenges, and this is quite acknowledged by countries. It is not that it's quite expensive. You need capacities, you need policies, because if not, then it will be quite expensive. It's not just negotiating the private sector, it takes long. Poor contracts, or even the poor ability of countries or ministries of health to manage the contracts would lead to probably more expensive, more riskier than you desire. This is also politically sensitive, particularly with the health sector, because it's a public service. So lots of engagement in the private sector has always been immediately criticized as outsourcing a public service. Poor contracts, as I said, means that you end up giving the private sector profits without transferring the risk. And also there's a risk that, if you put the private sector and you keep on contracting them, then you lose that public sector capacity, particularly, which is quite needed, as we have seen with the pandemic. So how is the private sector engaged? So usually it's procurement laws, right? This country's procurement law that governs it. Now, quite recently, we have now seen a lot of developing member countries actually come out with PPP laws. So, and this have actually, and these PPP laws are actually incentivizing or getting more private sector engagement in the health sector. And in a sense, in the health sector, although a lot of the lessons in PPPs are coming from outside health, what's sort of emerging is that when we start talking about PPPs, we could simply say it's either a health infrastructure PPP where you try to mobilize private sector financing in advance. So it's some actually call it like a procurement, where basically you get the private sector to invest upfront using their capital to build infrastructure, then subsequently get it transferred to the government, or they could provide the second part, which is clinical services in a different contract or part of the contract. The second type of PPPs are simply where you bring in the private sector to do clinical services. Then, of course, as we have seen in other countries outside of the region, you even have a health systems PPPs where the private sector bring in capital at the same time go into a contract where they're paid by government to provide the clinical services. What's quite interesting is that when we look at PPPs in general, these are all PPPs, and this was analysis that we've done. We're not actually seeing PPPs in Africa, Latin America. When the denominator is all types of PPPs, and in Asia has the lowest. So although health PPPs are quite accepted and quite common now in North America and in Europe, 1 out of 5 of the PPPs that we actually studied. In Asia, it's not yet quite common. But then COVID-19 happened. And what's quite interesting with COVID-19 is that we actually saw an upsurge or a lot of private sector engagement. Some call it PPPs. We could just call it private sector engagement across lots of countries, including something that's quite interesting, that there was a lot of private sector donation, let's call it funding, or corporate social responsibilities, which was basically donations, where the private sector provided resources to help the government respond to PPP. So in the Philippines, we saw it with what we call the T3 collaboration, where the private sector, including NGOs, built PCR laboratories, and similarly, we saw it in Indonesia. With the supply of vaccines, we saw it also in the Philippines, we saw it in Indonesia with the VGR. In Cambodia, there were private companies, large private companies, conglomerates that donated vaccines. We also saw it, and you go back. We saw it in IT, which is quite interesting. In most of the countries, the health apps that was used for contact tracing and all that were donated by the private sector. Probably just highlights that this capacity is not that present in a lot of government, in Ministries of Health in the region. Then hospitals and quarantines. So in Thailand, Philippines, you have private sector providing the hotels, providing hospitals in Thailand, the private sector building new quarantine facilities. So what, in a sense, COVID-19 basically is showing opportunities or lessons in which how governments should engage the private sector. So what are the main impact factors? And this is the last slide that we're actually seeing. Well, one, you actually need good laws. As I said, if the laws do not allow good contracts, or then you'll have a problem. So the presence of laws that enable the private sector and that also protects the government would be quite necessary. And as I said, we're seeing these laws now being passed in lots of countries. You actually need a strong government purchaser, because at the end of the day, when the private sector come in, so they either come in as capital, that means they will build the hospital, but they expect to be paid for that. Or they will come in with a contract on delivery of service and they expect to be paid for that. So you need a strong government purchaser who could do the contracts with these private sector partners. So in the Philippines, it's PhilHealth. In Thailand, we saw it's NHSO, SSO. In Japan, we have the government itself. Then we need to have the private sector willing to be engaged, who are willing to accept government contract, government rates, government fee schedules, government payment levels. And that's something that we have seen in the pandemic. It has actually opened up a lot of relationship, which was previously not there. And so hopefully this goodwill will basically continue on after the pandemic. And of course, you need government willing to work with the private sector. The 3 countries we have that has presented actually have governments. Historically, these are countries that are comfortable working with the private sector. We do acknowledge there are countries in the region where governments are very uncomfortable working in the private sector. So within the ADB, we see the private sector as part of the agencies, institutions that will help in development. And so we actually have a shop in ADB that helps countries develop PPPs, including health PPPs. We do also lending to the private sector. So in a sense, we believe that harnessing the private sector rather than treating them separately would be the better way in achieving development objectives, reducing poverty, sustaining the reduction of poverty, and of course, in achieving and pursuing universal health coverage. Thanks, Nima.
Thank you. So I'm going to start with question. I'm going to focus on specific countries just to give some flavors. So we have a question come here which looks about sharing of data, especially epidemiological data between public and private sector. Haruka, do you want to give some insights about how Japan is dealing, let's say, during the COVID or non-epidemiological data, and actually data sharing between the two different aspects? Thank you.
Okay, thank you very much. Actually, data sharing is a very huge concern or huge challenge here in Japan. Because the data at the healthcare facilities and then also data at the public health center, which is in charge of the COVID-19, is a bit different. But if we focus on the data at the healthcare facilities, now majority of the hospitals are introducing the electronic medical record, but those electronic medical records are not uniform across hospitals, which means data is not shared among the hospitals. And then when the government collects any data from the healthcare facilities or public health centers, those are not really a comprehensive system. And then some of you may know that Japan still uses a facsimile to collecting the data and sharing the data set, and it's quite hard. Recently, government announced that they try to uniform the electronic medical record across the hospital so that both the public and private sectors can easily to share the data among the hospital and then also among the government sectors. But yeah, there's many challenges in Japan at this moment. Thank you.
Thank you. I also have a question with regards to the quality aspect, which is for Thailand. Anika, the question is, do we see a big difference between the quality of care between the public and the private providers?
Thank you, Nima. So within the UHC system, so private and public providers that are contracted within the UHC, I would say there are no major differences. It might be by certain areas or regions, and this is primarily because of the mode of payment is capitation. So, I mean, within both the private sector and public sector, they want to meet a certain level of standards and quality of care because patients are able to choose which facilities they want to register at. However, if you're asking about private providers outside of UHC system, these may have higher or maybe lower standards. They may attract medical tourists, so they have higher level of care or higher quality of care in that sense. But if it's just within UHC, they have very similar standards requirements, and also they want to have patients. So I would say similar quality.
Thank you. I have a question on palliative care, and the question was basically the role of the private sector. Are any of the countries, and it's open to any one of the three, as well as Gabrielle, any of the countries who are focusing on the role of private sector on palliative care provision?
Okay, so in the case of Japan, of course, palliative care is a very important component, and then both public and private healthcare facilities provide palliative care for the variety of the patient. And then again, in my presentation slide, I explained that all the procedures, price of the procedure is set by the government. So this is the same to the palliative care. So any type of the palliative care provided at the healthcare facilities, the price are determined by the central government, and this price is the same between the public and the private.
Thank you. Gabrielle, do you want to answer the question with regards to the toolbox from the HSGF?
I would encourage people to visit the country connector on the private sector in health. We do have a toolbox on the connector, but there's other channels that you may want to visit, and you may want to engage through the support desk where we could provide more bespoke engagement and feedback. So it's just a nod to that.
Thank you, Gabrielle. I have a question which is a kind of a cross-cutting, so it's for everyone, I guess. It's from Anar, which is basically asking about the strategy to avoid cherry picking. Do countries actually have, in your experience, strategies for avoiding cherry picking in healthcare by the private sector? And as part of that, with regards to especially role of engaging the private sector on primary healthcare, and what are lessons learned? Can I ask Manuel, do you want to start? And then we'll go to Anika and Haruka.
Let me answer the second question about the role of the private sector in primary healthcare. Essentially, primary healthcare, private sector are, you might say, individual practitioners, okay, particularly in the provinces. And they provide primary care there, but they would be independent practitioners that would give these types of services. Now, private sector that actually integrates and as a company, for example, gives primary care services, very few. And in fact, most of the private sector participants in healthcare go for hospitals, and they usually build primary, secondary, or tertiary hospitals. But as you can see from the slide that I showed you, a lot of dominance in secondary and tertiary care. For the second one, on cherry picking, you know, it's the nature of the private sector to look at their bottom lines. And therefore, they're going to go where they can make a profit. And essentially, if you're talking private sector and insurance companies, for example, you know, insurance companies would actually, private insurance companies would actually, you know, ask you for very high premiums, as you know, for people with morbidities. Or at a certain age, they drop you off the roster. So what is good now is that the National Health Insurance Program now covers seniors as well, and they're automatically in the program. So even if the coverage is not 100%, you have some coverage for seniors under the National Insurance Program.
Thank you. Anika?
I guess in terms of cherry picking, if a primary care hospital or primary care center decides to refer patients that are less healthy and so on, they actually will get less payment when they ask for reimbursements later on. So if you are in the primary care center, you refer to the main contracting for no good reason, I guess, then yeah, so you'll get less payment when you are doing that. But in addition to that, hospitals don't get to choose who registers in their facility. So the patients are able to choose themselves where they want to register as their primary facility. So in that sense, cherry picking is decreased. And in terms of health insurance, the entire country is covered by UHC. So insurance can't choose poor, sicker patients or healthy patients. So hope that answers the question.
I'll come back to you, I think. Haruka, do you want to come in at this stage and then we'll see?
Because since 80% of the medical facilities in Japan is in a private medical institution, and then it is more of the main service provider rather than the cherry picker. And then I believe that they are probably controlled through the uniform fee schedule so that these medical institutions do not gain the huge profits. And then also to begin with, Japan does not allow for-profit company to open medical institutions. Therefore, for example, like joint stock companies are not allowed to open the hospital. So like it is the status of the public and private are almost the same in Japan. So like it is less likely that private medical institutions to be a cherry picker.
But Haruka, Japan is unusual because when we look at the other two countries, the private sector is dominating the hospital, the tertiary. And in Japan, it's the reverse. It's the primary healthcare, which to me sounds like the fee schedule seems to be such that they get more out of the fee schedule if you are a primary healthcare provider. Now that has implication vis-a-vis, if you like, the fragmentation of the service which you've mentioned, and that's lots of small providers. How do you see that changing?
Yeah. Okay. Thank you. That is a very good question. So, like every 2 years, the government revises the price of the already healthcare procedures. And then there is a huge negotiation among the, not only between the Ministry of Health and Ministry of Finance, but among the health sectors. So for example, acute care versus chronic care or tertiary care versus primary care, there is a huge negotiation about which part of the procedures can get a higher insurance rate, while the which part of the healthcare procedure that set the lower rate. And then usually Japan Medical Association has a huge strong power over the price setting procedures. And then Japan Medical Associations are consistent mainly of the private primary clinicians. So like in the past, it is said that the price control is not in favor of the primary care or the small to middle-sized primary care facilities. So which result into the partly result into the huge number of the healthcare facility, middle to small size healthcare facilities in Japan. But I think the situation has been changing, and then the political power of the Japan Medical Association has also been changing. And then now Japan Medical Association not only consists of the primary private healthcare providers, but they also consist in the healthcare professionals, those who are working in the secondary or tertiary care. So like the power, political power has been changing, and then
What you're telling me is that if you like, the fee for service are not shifting to more of the hospital or the tertiary care, they're getting more money, more percentage of the overall budget?
It depends on the division timing. So as said, Japan revised the price every 2 years, and then every time the result of the fee schedule differ. And then after the negotiation or after because of the political power or after the negotiation process, the decision of the fee schedule, which is in favor of the tertiary care or in favor of the primary care, is a totally different in every time. And then it is,
Okay, thank you. I have a question for all of you, and I'm going to ask Dodo to lead to begin with, if that's okay. We've talked a lot about service delivery aspect, but not so much about the role of private sector on financing of the healthcare. Apart from Dodo's presentation, what are your thoughts from your country experience when it comes to about financing the health sector, and how much is that getting involved, engaged, either from whatever means? Over, Dodo, do you want to start with?
Nima, as I said in the presentation, it's how you look at, how you define, private sector spending. Okay, so one is that they're seen as capital. So it's like if you go down to the story of Thailand, the story of Japan, those private hospitals basically were built using private financing. And so when they're built and now that they're contracted, in the case of Japan, it's the primary care clinics, and of course the Philippines, the private hospitals. Once they're there, we actually start contracting with the government payer. So in effect, the private financing can be argued to be supporting universal healthcare that has been achieved in Thailand and in Japan, because now the government does have to build the hospital. So it's capital. It's that done passively. Now, if you do PPPs, it's in a more active, organized manner, where you actually get the private sector to come in and say, look, we have a need. Instead of using government domestic revenue, budget money, we want you to do it in advance. Then we sign a contract where you will be paid for a number of years to do that. Or you try to get them to finance the equipment upfront and similar. So that's another way of looking at private financing. And of course, there's private health insurance financing, which some people also look as private financing, because in Asia, in the region, we actually have a lot of people flowing money to private health insurance. And that's a challenge now, how you get this private health insurance move from a parallel universe where it is in most of the countries, but actually work, there's a compatibility, it complements government financing for UHC, because at the end of the day, it's not bad money. It's it's still pooled, it's all that. You just want to make sure that it doesn't have the right now it's really more for the well-off. You actually get it to be aligned. So that's the form of private financing. So there are ways to harness it quite well, Ima.
Thank you, Dodo. Manuel, because the question as part of this is about the level of OOP, which is in the Philippines at the moment. So out-of-pocket expenditure, and as well as, if you like, the role of the voluntary health insurance and other sources of private financing, if you can elaborate on that.
Yeah, I think I answered that already. OOP is still very high. The figure that I got was 44% in 2020. Actually, I knew figures as high as 52. And therefore, the country is trying to bring that down. But the level of public investment into the system really isn't enough to be able to do that. And also the level of premiums for PhilHealth, doesn't necessarily give it that much resource to actually cover more of the reimbursements. And therefore, it remains high.
Anika, I know that there's a lot of conversation in Thailand when we talk about financing. Everybody says it's basically tax-based, but there is a vibrant private sector voluntary health insurance. And when I look at your slides, one of the things which I notice is that there is an awful lot of polyclinics which don't seem to be contracting with the UCS or with the SSS. How do they function? Because that means that there is private money entering that function, those facilities. Any insight on that?
So I guess just to give overall numbers first. So 73% of total health expenditure on health is publicly financed. In terms of private insurance, it's only about 13%, and then out of pocket is 9%. There are a lot of clinics that are not contracted. However, the numbers that I gave in terms of which clinics are contracted for Social Security office is not a good representative of the actual number. And the reason for this is that the Social Security office only collects the information of the facilities that are directly or the main contracting unit of the SSO. So those main contracting units, if they subcontract with private facilities that are primary care units or referral hospitals, these numbers are not accounted for. And so this could be a big percentage as well, which we don't have the numbers for. In addition to that, a lot of private clinics are usually run by dual practicing medical doctors that work in the public facilities during the day, and then at night or off hours have these small private clinics. And these are mostly out-of-pocket payments for small basic health services. So around it's not a big percentage in Thailand, I guess you could say. Yeah.
Thank you. Haruka, I asked you earlier on about privately about the various insurance schemes that Japan has as a means of actually financing some of the costs. If you don't mind, elaborate on that, because that's something which I think people will be interested in answers with regards to the schemes for the elderly, as Japan is entering an elderly phase of its population dynamics, demography. But also whether or not you have any numbers on the volunteer health insurance schemes, so that if you like the private as opposed to the government-based. Okay, thank you.
Yes, so the Japan has the two major types of the public insurance scheme, and then the one is the for employees, so employees health insurance system, which covers those who work for the company, and then each company is an insurer, and then the other type of insurer covers the people who are self-employed or retired, and then we call the national health insurance scheme, and it is insured by the prefectural government. And then because of the increasing number of the older population, those who are already retired, which means they move from the employees' health insurance scheme to the national health insurance scheme. And there has been a problem between, especially the financial imbalance between the employees' health system and the national health insurance scheme. So the government newly set another insurance scheme for the older population, those who are aged above 75. And then those insurance schemes are financed both by the employees' health insurance scheme and then national health insurance scheme. So we mainly have these three insurance scheme, all of our public insurance scheme. And then as said, Japan is a universal health insurance scheme, and then everyone required to join the universal health insurance system, which means the private insurance company played a very limited role. So usually they cover the out-of-pocket payment part, or for the compensation for the very tiny part, like the room charge or those parts. So the role of the private insurance company is very limited in Japan.
Thank you. There's a question which talks about preventative care, and which kind of brings everything together, because we're looking at specifically the primary healthcare functions, the role of the preventive care functions, and how do we engage private sector for the preventative care. From your experiences, how is that working? Are there any good practices? And let me ask Anika first, if that's okay, and then we can bring in the others. How robust are the systems in Thailand, if you like, to ensure that the private sector is actually doing a good job?
So both public and private sector are required to kind of meet the same level of preventive care services. And I guess the main mechanism of doing this is through payment mechanisms. So as I mentioned, both NHSO and SSSO provide additional payment for preventive services. So this is both as part of the capitation rate and also part of retrospective reimbursement and also project-based payments. So depending on the area, when they identify certain kind of preventive services that are needed, certain budget is allocated to that. And for SSO, for example, in addition to normal capitation rate for outpatient and inpatient services, there is an additional flat fee per patient for chronic disease as well. So in that sense, I guess payment mechanism is how it's done, and it is done pretty well. When we did the interviews with private sector, the additional payment for preventive care services is what made them want to kind of join the NHSO as a private provider.
Thank you. Manuel, I know that, in your slide, the PhilHealth slide basically shows that the preventative care budget is basically zero. How is that being covered in the Philippines? How is that being covered? If PhilHealth as the primary insurance is not covering it, what is the solution?
Well, I think there's a consciousness, Nima, that this has to expand. And in fact, PhilHealth is going to try to roll out a comprehensive outpatient benefit package where supposedly any outpatient condition will be covered. But it's very, very early days. So the conventional wisdom at the moment is where you're talking about public health and preventive care, it's government. Government has to do it. Private sector NGOs can probably, do advocacies. Some pharmaceutical companies are thinking of strengthening self-care approaches, but that's essentially it. A lot of the preventive care is public sector at the moment.
And in the public sector, they still have to pay OOP for that preventative care?
No. Generally,
right.
no. Preventive care services, public sector, that's free. But the thing is the coverage. Okay, for example, right. Vaccinations. Okay, you might have vaccinations, cervical cancer, hepatitis, etc. A lot of that would be covered, particularly for infants. But for adults, probably not. So the coverage would be lacking, even if the service would be available.
Thank you. Haruka, I'm not going to ask you this question because you're going to say it's the same thing for private and public, and it's a fee-based service. So I'm going to ask just one other question. Manuel, actually for you specifically, it's with regards to the change in government, because the UHC Act was the last government's big piece. And we've got a new government in the Philippines. How robust are these plans vis-a-vis the change in the government? And I can say that the same thing could apply to all three, that as you see the change in government, how are they plans for service delivery or the role of private sector is changing? So I'll start with you, Manuel.
Speaking optimistically, Nima, I think, as I said, we're at an inflection point. And therefore, the UHC Act actually provides a network to move this forward. What the previous administration has done is that they've actually laid out a lot of the policy frameworks, administrative orders coming out of your ears. The thing is, these administrative orders now have to be grasped and understood by the stakeholders. So coming to this next administration, I think they are committed. They are committed to pursue this mandate that has actually been enacted during the previous administration. The question is implementation, okay, and putting in the resources as well as the people who can implement going forward. But I would say that they have to be committed because this is already, I think, cast in stone.
Well, that's good to know that they've as you said, they've cast in stone so that it will happen. There are a couple of questions still. One of them is about the role of private sector and supply chain issues, which none of us really tackled it in here. And I wonder if you want to say anything, and then with that, we will close this session.
You know, the public sector here has a supply chain or a procurement system. It's terrible, okay? It's very lumpy, it's very inefficient, a lot of wastage. So it's the private sector that actually has very strong supply chains. And during COVID, they were able to help government with the supply chain system. So I would say that the public sector can learn from the private sector in terms of managing supply chains, or even contract the private sector to manage their supply chains. Thank you.
Haruka, do you want to say anything? Your video is on, so I'm going to pick on you.
I'm sorry, but I do not have much familiar with the supply chain system in Japan. But usually the private sector, of course, has a very important role for the supply chain in terms of the medicines and medical devices. But for the preventive measures and public health issues, I mean, public sectors are mainly in charge. So like the vaccination for or any other supplies that related to public health or preventive issues, in that case, public sector are mainly in charge. But other than that, usually the private sector are mainly in charge of the supply chains. I'm sorry, I do not have much knowledge about this topic, so sorry for that.
Thank you, Haruka. Dodo, you've put your video on, so I presume you want to say something.
I read the questions. So basically, I think a couple of questions you're being asked. Are the partnership in COVID-19 something that will still continue after the pandemic? We're seeing that. Oh, the pandemic is still there, but we're actually seeing really an openness now between governments and the private sector desiring to work with government. I think that's a good thing. Now with the supply chain, you know, and not just supply chain, IT. This is something lots of ministries of health really don't have the capacity or the skill set. Partly because the market is such that the good people here ends up being hired by the private sector. So for lots of countries, rather than trying to imagine themselves as an IT company, the ministries of health imagine themselves as an IT company or to become a DHL. I think it's better to move forward and get try to see and find the ways in which you could bring this in, this two particular part of where there is admittedly private sector expertise much higher than government, and bring them in. I'll stop there now.
Thank you, Dodo. Just one sentence, Anika, with regards to the ministry in Thailand. How are they engaging with the private provider on the supply chain issue, if you know anything on that? Because
I mean, I don't think I have that much knowledge on this particular topic. In terms of private providers that are within UHC, some, I guess, medicines and equipments are provided through public procurement. So vaccines, for example, are not usually privately procured. So in addition to that, I don't really have that much information.
Thank you. And I want to thank all of my panelists who've been involved for the last hour and a half. I think the challenge of looking at the private sector through three very different countries, a country which is very well established when it comes to using the private sector providers within a national agreed framework, a country which has starting the pathway of actually getting onto those national agreed frameworks, and complicated by decentralization of health as a service, and also a country where it is fundamentally a public sector provision of health, which has expanding into getting private providers in order to improve the coverage, is what we have seen in here. Three very different scenarios, three very different approaches to dealing with these, which just goes to show that how complicated it can be when you're actually dealing with multiple suppliers and funders of the health system. I want to thank all of you. I want to thank also the people behind the scene, Bruno Messen, Radhika Roro, and Valerie Dasonia, who've been involved in setting up this webinar. With that, I would like to also thank you for logging in and listening. Thank you and goodbye.